In fact, it's the third commonest arthroplasty that we do. Affects more women than men, and arthritis in the glenohumeral joint is a significant disease burden. 36 million people reported in the US with glenohumeral joint arthritis. So the causes are obviously primary osteoarthritis, post-traumatic deformity, inflammatory arthritis such as rheumatoid, post and septic arthritis, and avascular necrosis. It's also associated with shoulder instability, and cuff tear is present in about 5 to 10% of patients. It is more common in throwing athletes and in those who've had previous surgery with over-tightening of the anterior capsule, such as a putty plate procedure for recurrent anterior dislocations and Magnuson stack procedures. So typically presents with pain, crepitus, and possibly instability. The investigations that we need to do are a true AP view to visualize the joint space, look for joint space narrowing, osteophytes, and the size of the osteophyte in some literature may indicate the degree of osteoarthritis to mild, moderate, severe, and 3 millimeters is the value, less than 3 millimeters for mild, 3 to 5 for moderate, and over 5 mils for severe. If the head is humeral head is migrated superiorly, that might indicate rotator cuff insufficiency. Look for any previous staples from previous surgery. And medialization of the humeral head is more common in rheumatoid arthritis, and that might mean that glenoid resurfacing may be required. Also important to get AP views in internal and external rotation, and an axillary lateral to assess your glenoid bone stock, especially to look for posterior glenoid wear and posterior humeral head subluxation. You can get better assessment with CT scanning to look at, and also to assess the glenoid version, and also to look at the bone stock, especially posteriorly. There's a large study that's been used looking at CT, looking at version, and it varies. In one study, it says about 2 degrees of antiversion is sort of the normal that you should be expecting, and that's what you should be aiming for. Sorry, because the glenoid is often retroverted in osteoarthritis. So non-operative management, there's actually not much evidence of sufficient quality. Obviously, the non-operative management is like similar to what we do for any arthritis: analgesia, non-steroidals, and opioids. Physiotherapy or alternative therapies may be beneficial on a patient-to-patient basis. An intra-articular steroid injection, either blind or radiologically guided, may help, and glucosamine. There is weak evidence for any injectable viscosupplementation with sodium hyaluronate. This is actually one of the studies out of an EOS review. It was a level 4 evidence, but it was an industry conducted study. So obviously there may be some bias, but they found that pain, global assessment scores, and quality of life were much improved following viscosupplementation, and that was from Silverstein et al. In 2007. So in terms of the surgical options for glenohumeral joint arthritis, I'll go through shoulder arthroscopy, open debridement, non-prosthetic or biological interposition arthroplasty, arthroplasty, whether it be a hemi, total shoulder replacement, or reverse, and obviously the late salvage procedure of an arthrodesis I won't really go into. In younger patients, shoulder arthroscopy may have a role, but is likely to have a role into reverse conditions that are eminently treatable, such as subacromial bursitis, AC joint arthrosis, impingement, or rotator cuff tendinopathy. There's not really much evidence for any of the procedures here: glenohumeral debridement, capsular release, chondroplasty, microfracture, removal of loose bodies, biological interposition grafts, distal clavicle resection, biceps turoral labral repair with glenohumeral joint arthritis on its own, but further studies are ongoing. In terms of open debridement and non-prosthetic or biological interposition arthroplasty, there is obviously concerns in younger patients with shoulder arthroplasty, especially in terms of glenoid loosening and obviously survivorship and the need for revision. There's evidence is inconclusive to support an open debridement or any non-prosthetic or biological interposition arthroplasty, including any allograft, interpositional soft tissue allograft and autograft at this stage. So the mainstay often is arthroplasty, and it's quite a controversial area. Basically highlights the difference between hemiarthroplasty and total shoulder replacement. And really it's very important to look at preoperative planning and assessing these patients. And certainly the poor prognostic indicators are large bony deficiencies of the humeral head and glenoid. The function of the rotator cuff and deltoid is key. Any shoulder instability and any previous surgery, such as especially anterior chromioplasty and excision of the CA ligament, which might mean that with arthroplasty you get antero or anterosuperior dislocation. So it's important to look at plan the patients in terms of what the patient expects. The old-fashioned teaching was 90 degrees of abduction, 90 degrees of flexion, forward elevation. But some studies say that no forward elevation more than 130 degrees is what we should be counselling our patients, and that we should be encouraging that there will be functional improvement up to 18 months post-op. So to keep going with physiotherapy. Look at them clinically. We've got to look at if the patient's got excessive external rotation. That might indicate a subscapularis deficiency that might need addressed at the time of surgery with augmentation. Limited external rotation might indicate severe posterior glenoid wear, and that might need a more neutral version when we ream the glenoid. In terms of anatomical considerations, rotator cuff and deltoid status is key. Look for large tears or a non-functioning deltoid. Look at the bone stock. In osteoarthritis, like I said, you'll get posterior glenoid deficiency. With rheumatoid arthritis, you'll get central and medial erosion. Also look at the type and the extent of the soft tissue contractures and any asymmetric wear. So arthroplasty, both hemiarthroplasty and total shoulder arthroplasty, do provide significant improvements in pain, global health assessment, function and quality of life. And it's important to look at there is a classification of glenoid wear, which is the Walsh classification, type A, B, and C. It's more descriptive rather than actual guides management that much. So in looking at comparison of hemiarthroplasty and total shoulder, looking at pain and global health assessment scores, total shoulder replacement had significantly better outcomes over hemiarthroplasty for pain and global health, and there was no statistical difference in function and quality of life between the two procedures. And these are based on the highest level of evidence we have available from 2000 and 2005. And these were randomized trials. The indications for hemiarthroplasty, well, you need a concentric glenoid. And if you don't have one, if you can ream it to be concentric, then it's possible. The humeral head must be centered in the glenoid, preoperatively or intraoperatively, and you need less than 25% intraoperative subluxation of the humeral trowel component after you balance the soft tissues. Got about an 80% survival rate of hemi at 10 years, and the literature reports a higher revision rate with hemis done for trauma than for rheumatoid. Revision hemiarthroplasty is almost usually always for painful glenoid arthritis. So considering a younger patient with osteoarthritis under 50, over 50% of these patients may have subjective or objective unsatisfactory results. So you consider a hemi in post-traumatic cases, avascular necrosis, and in cases of massive rotator cuff tears. When you're doing one, you should strongly consider a modular humeral head design, because that means you can obviously remove the head in the future and not necessitate the full removal of the whole stem if you need to do a convert to a total shoulder. In terms of looking at massive rotator cuff tears and shoulder arthroplasty, a massive tear involves more than 5 centimeters and involves more than one tendon. And these are tears that can't be repaired even without a cuff mobilization. And glenohumeral arthritis may develop with massive cuff tears, but it's difficult to say exactly what the exact incidence is. The best study we have to date was done in 2001, highest level of evidence by Sanchez Sotelo. They evaluated the effects of hemi and massive cuff tear. 27% of patients had persistent pain at rest, and anterosuperior instability, like I mentioned before, occurred in 7 out of 33 shoulders and was more common when previous acromioplasty was performed. So the authors concluded then that the procedure was acceptable for patients with severe rest pain. So operative considerations: you need a functionally intact coracoacromial arch as a secondary stabilizer for containment of the humeral head, and you need a sufficiently small prosthesis so you don't over tighten the posterior capsule. That might involve oversizing the humeral head and disrupting the soft tissue tension anteriorly, leading to instability. And you should be able to get 50% inferior and posterior translation of the humeral head. Total shoulder replacement is not recommended for massive rotator cuff tears. Glenoid component loosening because of eccentric loading of the glenoid component is known as a rocking horse phenomenon and can cause loosening and failure described by patients as pain and loss of function, and that might necessitate revision. And there's no reliable studies comparing clinical or radiographic results of total shoulders in patients with and without irreparable cuff tears. Reverse total shoulder replacements in massive rotator cuff tears obviously rely on deltoid function. So if you've got a paralysed deltoid, that's actually a contraindication. This is showing promise of reverse total shoulder in some salvage cases, especially in the elderly patient, but you wouldn't consider it in the young patient because of problems with the glenoid. Indications for total shoulder arthroplasty are progressive pain, reduced range of motion of the shoulder, and loss of function. And contraindications are cuff arthropathy, deltoid dysfunction, and like I've said before, insufficient glenoid bone stock. There is evidence, like I said before, of total shoulder over hemiarthroplasty, and this was done in a prospective study by Gartzman in 2000 with in 51 shoulders, 24 hemis, 27 totals, with a mean follow-up of 35 years. So significantly better pain relief and better internal rotation with total shoulders, and a trend for better patient satisfaction, function, and strength in the total shoulder placement group. 5 operative considerations you need is in terms of the glenoid resurfacing in total shoulder. The non-concentric glenoid, you need that for obviously joint congruency and reduction in eccentric wear. The design of your component is important as well. There's been recent studies that look at with stereometric analysis, looking at micromotion, comparing the PEG glenoid and the keeled component. And the cemented PEG components seem to have less micromotion and better lower loosening rates, but that's still being evaluated. You want to get your glenoid version right, so you're looking for a version of around 1.23 degrees of retroversion. That's in a large cadaveric study looking at 344 human scapular bones. Sorry, that was a CT CT study, sorry, not cadaveric study. You also want to consider bone loss, and you might be necessary to alter the amount of humeral retroversion that you have to a less retroverted position. So that you position your glenoid more retroverted than you normally would, but your humeral head in less retroversion to cancel the two out. You can consider posterior augments in severe posterior erosions, and for central bone loss, bone grafting or a larger cement mantle. It's also important to look at the center point for your reaming for your glenoid, and that's this lateral aspect of the subscapularis fossa, midway between the lateral and superior borders of the scapula, and the true center of the glenoid is slightly lower to that midpoint. In terms of glenoid component prosthetic design, importantly, there's no strong evidence to support one prosthesis over the other at this stage. So your options are a metal back, screw fixation, trabecular metal, or biological. And there's only been one systematic review looking at this. The total shoulder, but that was done by Radney et al. Total shoulder replacement maintains low rates of glenoid loosening and lower rates of revision surgery, looking at especially when you use an all polyethylene glenoid component. And that metal back glenoids have a 6.8% revision rate. However, the revision rate for all polyethylene glenoids was a lot lower at 1.7%. So, looking at the humeral component, the prosthesis design, and the method of fixation, there's no published high-level evidence to support either the type of humeral stem, although modern designs, because there's over 70 designs available, they allow good replication of the patient's normal anatomy with a lot of modularity, and there's no evidence to suggest that cemented versus uncemented humeral stems do better. The surgical approach has also been looked at for total shoulders in terms of whether you do a subscapularis transtendinous approach or a lesser tuberosity osteotomy. The problem with the transtendinous approach is non-healing or rupture of your subscapularis, which can lead to poor results in terms of pain and loss of function, and sometimes instability, such as subluxation or even dislocation. So some authors are preferring to use the lesser tuberosity osteotomy to get more reliable bone-to-bone healing, not relying on tendon-to-tendon or tendon-to-bone healing. So in terms of generalized complications, hematoma, fractures, and loss of tuberosity fixation are very important. Some fractures, if they're long, oblique, or spiral, can be managed non-operatively, as long as good alignment of the prosthesis is maintained and of the fracture. Transverse or short oblique fractures might not heal, necessitating operative fixation. Loss of your tuberosity fixation is really essential when you do these operations to get good, secure repair at the end. And when that doesn't happen, that's when poor post-operative outcomes can be expected. In terms of instability, you can be classified into early or late. If they occur early in the post-operative period, it can be due to malposition of the implant, which is the number one thing you've got to look at, soft tissue imbalance, or inadequate post-operative protection of your patients. Your management then involves reduction, if possible, and immobilization. There's no current evidence to support the duration of immobilization after that. Late dislocation can occur with obviously progressive cuff tears, component loosening, or glenoid wear. The instability you get post-arthroplasty can be superior, inferior, anterior is the most common, or posterior. Specific complications of total shoulder replacement are when you've got excessive offset. Obviously, with a glenoid component, you lateralize the humeral component, and that places subscapularis under increased tension and can risk rupture, leading to problems. You've got to avoid excessively large components and neck lengths because that increases your capsular tension and results in reduced range of motion and increased instability. There are certain ways you can assess the offset intraoperatively by passing a finger between the acromion and the head of the prosthesis, and you should be able to inferiorly translate the humeral head so that half of the glenoid is exposed. You can also see if you can translate the humeral head posteriorly to expose half of your glenoid. And also you should be able to get abduction of the arm to allow, with the arm abducted, 70 degrees of internal rotation and 40 degrees of external rotation. And that'll allow you to see whether you've got the offset roughly right. It's more likely, obviously, to get excessive offset in a total shoulder, because obviously the glenoid component will add to everything. Glenoid loosening is specific to total shoulders, obviously. Many cases fail to show loosening in the early stages because you don't get an X-ray beam that's perpendicular to the bone cement interface, so it's important to look for that. And you might well see radiolucencies in about 60% of patients. In terms of revision rates, hemiarthroplasty it does vary in the literature. 40% revision rate of hemi to total shoulders, like I've said before, usually due to glenoid arthropathy. Total shoulders, there's no revisions to hemiarthroplasty. And that's supported by 2 high-level studies, level 2 studies. The complication rates have been reported in the literature to be higher in those surgeons who do less than 2 arthroplasties a year. And that's showed increased immediate post-operative complications and increased length of stay. There's no evidence to suggest that the late complication rate is greater in the high versus low volume surgeons, and there's no patient outcome measurements or clinical assessments available for that. In terms of DVT prophylaxis, there's no evidence support either way. It's a surgeon-specific thing. Although looking at physiotherapy after shoulder arthroplasty, we invariably do it and encourage patients to do it up to 18 months. However, there's no high-level quality studies to actually support that it improves outcome.